uveitis, with a particular focus on sight-threatening retinal inflammatory disorders. Posterior uveitis is often considered a scary area of ophthalmology, and it's a very large subject that will be impossible to cover entirely in this talk. The purpose of the lecture is to give you an awareness of the clinical features and the conditions that you shouldn't miss. We'll start with a refresher on how to classify the different types of uveitis, then cover the importance of a thorough history in this cohort of patients, then go through some examples of the immediately sight-threatening conditions. Alright, these images do a nice job showing the difference between the types of uveitis based on location. So there are many ways to classify uveitis, but if we start with the most common way by anatomy, this basically means we're talking about which part of the eye is inflamed the most. Now, anterior uveitis refers to inflammation in the iris, ciliary body, or the front chamber of the eye. That doesn't mean there can't be effects in the back. The posterior segment, cystoid macular edema, optic nerve swelling can happen even with anterior uveitis. This is because tiny white blood cells in the front chamber release inflammatory chemicals called cytokines. These cytokines travel back through the vitreous and reach the retina. When the chemicals hit the retina, it causes it to swell, or macular edema. Leaky blood vessels can also contribute to the macular edema, and swelling can occur at the optic nerve as well. So even inflammation at the front of the eye can cause inflammatory processes to spread to the back. So moving on, when the main problem is in the vitreous gel itself, or the area around the pars plana, we call this intermediate uveitis. And when the inflammation is predominantly restricted to the retina, choroid or retinal vessels, with no significant changes in the front of the eye, this is called posterior uveitis. So a key diagnostic feature of posterior uveitis is the presence of fundus changes. These changes can range from retinal choroidal lesions or vascular abnormalities, which we'll discuss later. Finally, panuveitis is when all parts of the eye are involved. So that was how you would classify uveitis anatomically, and then you can also do it based on the pathology of the underlying cause. So is it infectious, non-infectious? Is there a masquerade syndrome? An important question with uveitis is whether it's infectious or non-infectious. One of the biggest clues is usually that it's often unilateral and severe. Severe uveitis in one eye is more likely to be infectious, especially if it involves the back of the eye, and we'll show some examples later on. Then masquerade syndromes, these are essentially uveitis caused by something mimicking true uveitis. For example, some cancers, especially lymphoma and leukemia, can cause large number of white blood cells to enter the eye. These can look like the white blood cells seen in infectious or autoimmune uveitis. Then beyond infectious, non-infectious, it's also helpful to know if the presentation is granulomatous or non-granulomatous. Granulomatous uveitis can cause characteristic findings like mutton fat keratic precipitates, which are deposits on the cornea, or vitreous snowballs, which are inflammatory clumps in the vitreous. We can also classify uveitis by its course over time. This can be helpful for diagnosis. For instance, a benign cause is more likely if the uveitis is acute and hasn't lasted a long time. So you can describe it based on the duration. Is it acute, sudden onset, short duration, or persistent, continual? And then if it's chronic, long-lasting, or recurrent, i.e. multiple attacks with periods of no inflammation in between. And the table below is a good representation of that. So this is a reminder that it's absolutely necessary for dilation in all cases of suspected uveitis. Even if the inflammation seems confined to the front of the eye, the posterior segment can be still involved. Missing this can lead to delayed diagnosis and, in some cases, irreversible sight loss. Conditions that we'll discuss later, such as acute retinal necrosis, can progress rapidly. So working in a uveitis clinic is a bit like being a detective. Taking a good patient history is really important in these patients because it can often point us towards the cause, especially when we're trying to distinguish between infectious and non-infectious types. So it's important to establish, the onset. Was it sudden, acute, or gradual, insidious? Is this their first attack, or are they recurrent episodes? Do they have common symptoms of anterior uveitis, such as pain, photophobia, maybe some blurred vision? Are there floaters with blurred vision, flashing lights in the vision, which may indicate deeper involvement? Have they got a history of previous intraocular surgeries? You may want to consider post-op inflammation or endophthalmitis. Then think of risk factors. Are they immunocompromised? Inquire about recent illness, past medical and family history, travel history. Some infections are more common in certain countries. They may have just come back from somewhere like Thailand where they've had some fun, and be more at risk of sexually transmitted diseases. Moving beyond the general history, we can then delve deeper with some specific questions to pinpoint the cause. As I mentioned about travel, you may ask about potential TB exposure. Were they born in a high-risk area? Do they have family members with TB? Then you may inquire about fever, night sweats, weight loss. Discuss the patient's respiratory symptoms. Do they have shortness of breath and cough? May suggest things like sarcoidosis. You'd follow up with questions about skin lesions or fatigue. Then thinking about musculoskeletal pain, especially morning stiffness that may improve with activity. This may suggest a rheumatic condition like ankylosing spondylitis, which is associated with the HLA-B27 gene. This is in contrast with things like osteoarthritis, where the pain worsens with joint use. Then you may ask about the sexual history and safe sex practices to rule out things like STIs, syphilis, HIV. Then there are rarer things like Lyme disease. You may inquire about recent tick bites, childhood uveitis. Did they have uveitis as a child? Some conditions like juvenile idiopathic arthritis can present with uveitis flare-ups in adulthood. Then you may consider sort of the neurological state, ask about episodes of weakness or numbness, which may indicate things like MS. So posterior uveitis has some distinctive features that set it apart. Terminology you may have heard of, such as retinitis, which refers to inflammation of the retina itself. And you'd often see lesions or hemorrhages in the retina. Chorioretinitis involves both the choroid and the retina, typically presenting with sort of yellow-white lesions. Vasculitis, which is inflammation of blood vessels, can also occur, affecting either the veins, phlebitis, or arteries, arteritis. So looking out for these features along with others help to sort of pinpoint the specific types of posterior uveitis. In the images on the screen, we can see in the top image some peripapillary chorioretinitis with associated vasculitis, a phlebitis, and in the image below there is sort of retinal vasculitis with retinal hemorrhages supranasally to the optic disc. So posterior uveitis can lead to a variety or cascade of complications that threaten vision. These include optic disc edema, macular edema, secondary CNV, retinal detachments, retinal ischemia, and ocular hypertension. So here is an example of a patient with neuroretinitis with optic disc swelling and macular exudates. This fluorescein angiogram shows peripheral non-perfusion with a small area of hypofluorescence corresponding to chorioretinal lesions along the retinal blood vessels. And finally, this OCT angiography scan demonstrates a secondary CNV in a patient with chorioretinopathy. And here are some more examples of complications, including choroidal ischemia seen on an ICG. This slide shows some signs and symptoms which should raise immediate red flags that warrant urgent attention for potential sight-threatening pathology. These include, immunocompromised or sick patients, somebody presenting with rapidly decreasing vision, severe pain, significant vitritis, the presence of retinal lesions, retinitis and vasculitis. The next part of this talk, we will consider if the condition poses an immediate threat to vision. Sight-threatening posterior uveitis is rare, but of course it's critical to recognise and identify at-risk patients. We'll cover infectious and non-infectious causes. Acute retinal necrosis, or ARN, is a rapidly progressing viral necrotizing retinitis, primarily caused by herpes simplex virus, HSV1 and HSV2, varicella zoster virus, VZV, and in rare cases, cytomegalovirus, CMV. It can affect both immunocompetent and immunocompromised patients, with VZV-ARN more commonly occurring in older patients due to declining cell-mediated immunity, while HSV-related ARN is more frequent in younger patients. A major concern with ARN is the high risk of severe vision loss due to its rapid progression and complications like retinal detachment. When evaluating a patient, it is essential to consider any recent viral illness, immunosuppressive treatments, or a history of HSV or VZV outbreaks, including genital herpes, cold sores, or shingles. This table shows the clinical presentation of ARN. Patients typically present with floaters and blurred vision, and in cases with significant anterior segment inflammation, there'll be ocular pain, injection. Vision loss tends to be more significant or worse in those with severe vitritis. The diagnosis of ARN is primarily clinical, supported by imaging and laboratory findings. On fundus examination, it's characterized by white necrotic retinal patches in the periphery, accompanied by an occlusive vasculitis and often a severe vitritis. The presence of a raised IOP may also suggest herpetic etiology. OCT imaging reveals full thickness retinal loss of identifiable layers, signifying sort of extensive ischemia and necrosis. Fundus autofluorescence imaging can help highlight areas of disease activity, sometimes before they become more clinically apparent. Ultra-wide-field fundus photography, such as Optos scans, are really important for monitoring disease progression, especially when there are media opacities which limit sort of direct visualization. Fluorescein angiography isn't required for diagnosis, but it can demonstrate things like occlusive vasculopathy. PCR testing of the aqueous or vitreous humor is the gold standard for confirming the viral etiology. So in this image of a right fundus, you can see peripheral necrotic patches temporally. This Optos ultra-wide-field photo of a right eye shows some peripheral vasculitis with temporal retinal necrosis and a serous retinal detachment. And in these images, you can see a fundus photo showing necrotic patches with active retinitis. The corresponding OCT scan shows severe thinning and loss of identifiable outer retinal layers, as well as vitreopapillary adhesion. So urgent treatment is essential to prevent severe vision loss. Systemic antivirals, typically intravenous, should be initiated immediately. Intravitreal antiviral injections such as foscarnate are also used. Oral antivirals like valganciclovir are used for maintenance. And systemic corticosteroids may be introduced later on to control the inflammation. despite early and aggressive treatment, visual outcomes remain guarded due to the high likelihood of retinal detachment and extensive retinal damage. And as discussed on, is rare, but a devastating condition, and you should have a high degree of suspicion in patients with unilateral panuveitis with severe vitritis. So, cytomegalovirus (CMV) retinitis is a slowly progressive necrotizing retinitis caused by CMV, typically occurring in immunocompromised patients, such as those with advanced HIV, AIDS, or transplant recipients. Unlike ARN, which typically presents with a significant vitritis and peripheral necrosis, CMV retinitis usually affects areas around the optic nerve and blood vessels, with little to no vitritis. The classic presentation includes painless vision loss, and fundus examination reveals hemorrhagic necrotizing retinitis, often described as a pizza pie appearance due to the combination of retinal whitening and hemorrhages. Management includes intravitreal antivirals, along with systemic valganciclovir. For HIV/AIDS patients, it's important to optimize highly active antiretroviral therapy. So in this fundus image, we see a left eye with CMV retinitis with the classic pizza pie appearance. There's retinal necrosis with a few retinal hemorrhages and areas of perivascular exudation. In these images, we can see a right fundus image of CMV retinitis with yellowish white retinal necrosis around the disc. The corresponding OCT shows an exudative retinal detachment in the macula with significant thickening and hyperreflective changes. The OCT shows loss of identifiable layers in the retina. An example of another rapidly progressing necrotizing retinitis is progressive outer retinal necrosis, or PORN, caused by VZV. It primarily affects immunocompromised individuals. Unlike ARN, PORN is characterized by the absence of vitritis. There is predominant outer retinal involvement and early involvement of the posterior pole. There may be minimal retinal hemorrhage and a paravascular clear area. Treatment involves urgent IV antiviral therapy. And unfortunately, despite treatment, PORN carries a poor visual prognosis. In these fundus images, we can see patchy outer retinal atrophy in the posterior pole. The OCT scan shows cystoid macular edema with outer retinal disorganization. Syphilis is caused by the bacterium Treponema pallidum. It is a sexually transmitted infection known as the Great Mimicker due to its ability to resemble a wide range of inflammatory and infectious ocular diseases. Ocular syphilis can present with a variety of ways, but the most common and characteristic is syphilitic retinitis, particularly in cases of recently acquired syphilis. Syphilitic posterior uveitis typically involves an infiltrative retinitis, often presenting with an appearance of the classic posterior placoid chorioretinitis, which is a boggy texture with a yellow colour. Other clinical features include retinal arterial involvement, round vitreous opacities, and disc edema. Given its wide variability, any suspicious form of uveitis should indicate syphilis testing. Systemic features such as ulcers, rashes, and skin changes on the palms and feet should be considered, along with a history of risky sexual behavior or previous STIs. Diagnosis requires serological testing, and if neurosyphilis is suspected, particularly in patients with neurological symptoms such as headaches, hearing loss, or cranial nerve involvement, a lumbar puncture with CSF analysis may be indicated. Treatment consists of intravenous antibiotics. In severe cases with extensive inflammation, systemic corticosteroids may be used as an adjunct. Finally, It's important to remember that given the potential for misdiagnosis and the varied ocular presentations, you should always consider syphilis in any case of posterior uveitis or unexplained retinitis. In this Optos ultra-wide field image of a left eye, we can see the classic posterior placoid chorioretinopathy. There are regions of placoid retinal opacification involving the macula and the mid-periphery. This diagram is just a reminder that when assessing patients with suspected retinal inflammatory disease, it's important to consider the whole body, as syphilis can affect different parts of the body. In this image, we can see sores and rashes on the patient's palms. Toxoplasmosis retinochoroiditis is the most common cause of infectious posterior uveitis worldwide. It's caused by Toxoplasma gondii, which is a highly adaptable parasite with multiple transmission routes. It can affect both immunocompetent and immunocompromised individuals. The classic presentation occurs in immunocompetent patients as a reactivation of latent infection. It appears as sort of fluffy white-yellow lesions of focal retinitis adjacent to a pigmented chorioretinal scar. A pattern that's very characteristic, which is why toxoplasmosis is considered in these cases until proven otherwise. The lesion is often accompanied by an intense vitritis, which is sometimes known as headlight in the fog. This is due to the contrast between the bright retinitis and surrounding inflammatory haze. Patients typically present with decreased vision and floaters, and some may have mild ocular discomfort or elevated intraocular pressures. In immunocompromised patients, toxoplasmosis can have a significantly different presentation. Instead of the classic reactivation pattern, lesions tend to be larger, multifocal and bilateral, sometimes mimicking other infectious causes such as CMV retinitis or syphilis. There are several key ways people can become infected. These include exposure to cats. Cats are the definitive host for the parasite. Exposure to cat feces, particularly through letterboxes, can be a significant source of infection. Consumption of contaminated food with Toxoplasma oocytes through contact with infected animals or contaminated environments. Eating undercooked meat can harbour tissue cysts containing the parasite. Patients with weakened immune systems, such as those with HIV, undergoing chemotherapy, or have received organ transplants, are at significantly high risk of developing severe toxoplasmosis. So toxoplasma infection is particularly prevalent in Latin America and tropical countries, exceeding 60% in many areas. Brazil in particular has been identified as having one of the highest rates of toxoplasma infection in the world. This is an example image of reactivated toxoplasmosis with a chorioretinitis affecting the macula, adjacent to an old chorioretinal scar. Diagnosis is primarily clinical, but serology is used to check for antibodies. Treatment aims to control the active infection while minimizing inflammation-related damage. In immunocompetent patients with peripheral lesions that are not vision-threatening, treatment may not be required. However, in cases involving the macula, optic nerve, or significant inflammation, antimicrobial therapy should be initiated. Treatment consists of antiparasitic drugs, with adjunctive corticosteroids introduced after antimicrobial therapy. So, of course, urgent referral is indicated for these at-risk patients. Another condition that's important not to miss is infectious endophthalmitis, a sight-threatening intraocular infection that can occur post-surgery, post-trauma, or from systemic infections. It presents with a painful red eye, severe photophobia, hypopion, corneal edema, fibrin in the AC, and dense vitritis, typically with severe visual decline. A history of recent ocular surgery, intravitreal injections, or systemic sepsis should raise suspicion. Diagnosis involves fundus examination, ultrasound imaging, and vitreous tap with gram stain and culture for pathogens. Treatment requires urgent IV antibiotics with systemic antibiotics if endogenous source is suspected. It's important to refer these patients urgently for vitreoretinal assessment. So these are some images from a patient with an infectious endophthalmitis following an intravitreal injection. You can see in the top image a severe anterior uveitis with hypopyon and fibrin in the anterior chamber. This fundus image shows a left eye with an active vitritis and retinitis. There's temporal and inferior white subretinal lesions with overlying retinal hemorrhage. In cases where dense vitritis makes it difficult to assess the retina, a B-scan ultrasound is often needed to assess the retina. In this image, we can see that unfortunately the patient has developed a retinal detachment. Moving to non-infectious causes, Behçet's disease is a systemic inflammatory vasculitis strongly associated with HLA-B51 positivity. It is more prevalent in regions along the historic Silk Road, particularly in countries such as Turkey and Iran, where it has a higher incidence. Ocular involvement occurs in up to 70% of patients and is associated with a high risk of sight loss. The characteristic ocular feature is a relapsing uveitis, which may involve the anterior segment, posterior segment, or both. Anterior uveitis will always be non-granulomatous. In terms of posterior segment inflammation, it is characterized by diffuse vitritis, retinal infiltrates, sheathing of predominantly retinal veins, and occlusive vasculitis. Fluorescein angiography is used to monitor inflammatory activity in these patients. Systemic manifestations include recurrent oral ulcers, genital ulcers, and skin lesions. Treatment for Behçet's involves immunosuppressive drugs like steroids, and for tougher cases, biologic treatments like anti-TNF agents help to control the inflammation. Here is some retinal imaging of a patient with Behçet's uveitis. The fundus images show an active retinitis and occlusive retinal vasculitis, which is confirmed on the fluorescein angiogram. The OCT image shows macular edema and retinal disorganization. There are various autoimmune diseases, including lupus, rheumatoid arthritis, polyarteritis nodosa, or PAN, and sarcoidosis, which can cause aggressive retinal vasculitis, leading to ischemia and vision loss. This is why it's important to ask if the patient has any known autoimmune conditions or recent systemic inflammatory symptoms. Diagnostic clues include SLE or lupus vasculitis with occlusive changes on fluorescein angiography, PAN with necrotizing vasculitis, and UVAN presenting with retinal aneurysms and periphlebitis. These conditions require systemic immunosuppression to prevent sight loss. This case involves a 60-year-old woman who initially presented with foggy vision that progressed to near complete vision loss in her left eye. She was evaluated in her local emergency department, where they noted a mild vitritis, retinal hemorrhages, and elevated IOPs. She was started on Pred40 and Cosopt eye drops and orally cyclovir 400 mg 5 times daily. Unfortunately, despite treatment, her symptoms and clinical appearance worsened, prompting a referral to a tertiary centre's emergency department 1 week after her initial presentation. An important consideration is that she has a history of HSV encephalitis. This is an ultra-wide field image of her left eye, which was taken by the tertiary centre's emergency department. You can see a significant vitritis, bioscore 4, and hemorrhagic retinal vasculitis. There is optic disc swelling, and the macular OCT shows retinal swelling and disruption of the retinal layers. In the emergency department, a vitreous tap was performed for viral PCR microbiological cultures. Given the concerns for viral etiology, her antiviral treatment was escalated, and she was switched to valacyclovir and admitted for further management. She later received intravitreal Foscarnet injection. The viral PCR has since come back as positive for HSV1, and she has confirmed diagnosis of ARN. Her case is ongoing, but unfortunately the visual prognosis is poor. The case highlights the importance of recognising high-risk patients, ensuring prompt diagnosis and referring urgently for appropriate treatment to optimise outcomes. So it can be tricky to diagnose and manage retinal inflammatory disorders. When assessing these patients, think of the red flags and risk factors we've discussed. Urgent referral is essential for patients presenting with rapidly progressive vision loss, severe vitritis or retinal vasculitis. It's important to discuss for the patient systemic symptoms such as fever, weight loss, ulcers, rashes and joint pains, along with key risk factors like immunosuppression, recent infections, sexual history or ocular surgery. So thank you very much for listening to this talk, and I wish you all the best with the rest of your